Hi, back again with another dive into our Introduction to Microbiology textbook by Tortora. We are up to chapter 14 and we'll be taking a look at principles of disease and epidemiology. This is a relatively short chapter compared to what we've been doing, but it's a lot of definitions, so please bear with me as I just run through those definitions with you to kind of familiarize them, and then you can study them on your own and make sure if there's any you don't know, you can create a little vocabulary list for yourself. All right, let's take a look at this chapter. There's a beautiful micrograph as always to open the chapter. Clostridium difficile. And we'll talk about that quite a bit more when we talk about diseases of the GI tract. You already know Clostridium is that genus of gram-positive bacilli that produce endospores and are anaerobes. And this particular one causes inflammation and ulceration even of the colon, the intestine. All right, so starting out, some vocabulary terms. Pathology, that OGEY means the study of, you probably knew that. In this case, pathology means study of diseases of the body. Etiology means the investigation of the cause of a particular disease. So we talked about how Louis Pasteur and Robert Koch demonstrated the specific germ cause of a particular disease, particular bacteria. They were getting at the etiology of the diseases, so we'll use that term a lot from now on to talk about what's causing a particular disease, what microbe, what microorganism. Excuse me. Pathogenesis is the process by which the disease develops. Infection means that the body is being colonized by microorganisms. They've gotten in somewhere where they have access to some nutrients in your body and they're basically eating you up. And in so doing, they cause problems. Disease, an abnormal state in which the body is not functioning normally. So we get an infection with a pathogen, and by some various set of circumstances, whether it causes damage to a certain cell type of the body or a toxin is produced, any number of things that happen results in disease, some abnormal functioning. There's quite a lot of microbes that come in contact with our bodies, and some are transient. Just maybe ingest them from an unusual source of food that we don't normally eat, and they're in our intestine for a while, and then they're out and gone. Or we may encounter somebody in a different part of the country, may go on a trip and touch up against some people that introduce us to some microbes, and they come and then they're gone. Normal microbiota are ones that normally colonize our bodies. They live in our skin, they live in our digestive tract, they live in our nasal cavity, any number of places, and they're just normally present there. Here's a term that can be confusing. Symbiosis is the relationship between normal microbiota and the host. Now, symbiosis, almost by the way it sounds, seems like what it's going to say is, wow, these two organisms or species help each other out. They both contribute to some wonderful, happy existence. Well, that's not what symbiosis means. It just means that there is a relationship between them. So keep that in mind. Commensalism is one form of symbiosis in which one organism benefits and the other is unaffected. So many of the microbes that are in our intestine, we call them commensals. And they're just in there and they're getting a free meal. We're eating a lot of food and they're in there eating up the nutrients and multiplying like crazy. Then they pass out of the body, but a lot of new ones are continually dividing as the food passes from the stomach down through the intestines. Mutualism is that wonderful rainbow situation, butterflies and zebras, as Jimi Hendrix once said, both organisms benefit. Everybody's happy. Everybody gets something. Parasitism is a situation where one organism benefits at the expense of the other. The other one gets a detrimental experience out of the deal. And then finally, some microbes are opportunistic pathogens. They're there, but if they ever get a chance, they'll cause disease. So many microbes that are commensals or mutualistic on our body may become opportunistic pathogens if they get introduced into a different compartment of the body. For example, if we have an injury and they're allowed to escape from the digestive tract into the peritoneum, or we get a cut on the surface of our skin and bacteria get inside into the body that way. We may have an infection, a UTI. Some bacteria from the GI tract may get into the urethra and into the bladder, stuff like that. So those are opportunistic pathogens. Another example of opportunistic pathogens is when if your immune system becomes compromised. Let's say you have a severe trauma or a surgery. Oftentimes the immune system is knocked back on its heels for a period of time under those circumstances, and you may experience some infections as well as introducing microbes into new compartments of your body, as well as your immune system's kind of not as effective. Or you may have an acquired immunodeficiency if someone got infected with HIV virus and their immune system became very compromised, then a lot of the microbes that are normally present in or on their body may take over and start really causing serious problems. Those are called opportunistic infections. There's a couple of examples. There's a lot of microbes in your oral cavity and your nasal cavity, and they're normally present in there and normally commensals. But again, if you have some way that they can get a foothold in your body where they shouldn't be, then you can have disease. A lot of microbes in your colon, tremendous amount. Some microbes are always trying to get into your urethra, whether you're into the female or male urethra. They can only get in just so far before some sterile urine comes shooting out and blasts them out again. Occasionally, some can get up into the female urethra, up to the bladder, because the urethra is much shorter. They have a predisposition for getting urinary tract infections because of the shortness of that pathway. Microbial antagonism. Some microbes antagonize each other. Some block the growth of the other, or create conditions that are inhospitable to the other. Normal microbiota protect the host. So again, a lot of bacteria that are just commensals, they aren't really helping us directly, but they are helping us actually because they occupy niches that other bacteria, which may be pathogenic, would otherwise occupy, but they can't get to it. They can't divide and multiply quickly enough. They can't cause disease because there's just too many. In the intestine, for example, there's so many E. coli and so many Bacteroides that other species of bacteria, which may well be present, can't really grow enough, can't get outcompete all those other bacteria enough to grow up to the point where they can cause disease. Some bacteria produce acids, which inhibit the growth of pathogenic bacteria. For example, in the vagina, there are lactobacillus oftentimes that grow in there, and they eat the glycogen that's on the vaginal epithelium. It's that stratified squamous epithelium and has a lot of glycogen stored in the epithelium, and the lactobacillus love that glycogen. They keep things acidic. Very few microbes can grow in there. If that acidic pH is lost, then that opens up the door for other microorganisms to overgrow, such as Candida albicans, and get a yeast infection. Producing bacteriocins. Bacteriocins are peptides that inhibit growth of bacteria or kill other bacteria. So those are some ways that bacteria can benefit the body and slow down the growth of things we really don't want. Probiotics is a very popular theme or topic right now. About every manufacturer of yogurt will claim it as a probiotic, because probiotics just means introducing microorganisms into your body that will hopefully have some impact on the community that's living in your intestine. The thing is, you have to introduce a tremendous amount of microorganisms into your body to really have any impact on the balance of things in your intestine. So most of the time when you eat microorganism-rich foods, such as maybe some yogurt, even if it hasn't been pasteurized or anything, it's not going to be really enough to do anything. There are probiotics you can buy, though, that are guaranteed to have a very high number, a high count of bacteria in them, harmless commensal bacteria that can be introduced. You can eat them and they will go into your intestine and help repopulate with some bacteria that are considered to be good. There's a lot of emphasis on what is the impact of the various microorganisms that live in the community of microorganisms in your intestines on your overall health. It's called the microbiome. What's the total number of species and in what fractional presence are they, and how does that impact your health? There's a lot of interest in sometimes when people get diseases or get sick, it's partly because the microbes in their gut are out of balance. And what if we could restore that balance? And that might help remediate the disease. So there's a lot of very cool stuff going on with respect to studying the microbiome, the human microbiome, particularly in the digestive tract. So again, we define disease, we define etiology. Disease, the abnormal state in which the body's not functioning normally. Etiology is the study of the specific microbial cause of infectious diseases. And Koch's postulates we've already examined. If we want to establish the etiology of a disease, then we look to Koch's postulates as much as we possibly can. And here's the list again. I know you've read these before, but let's go through them real quick. So when we think a particular microorganism causes a disease, we must discover that pathogen in each case of the disease, and it also should not be present in normal hosts. Maybe we could add a little addendum on here. We should not find that exact same microorganism in healthy species, members of the population, but we should find it in every case of the disease. It is possible that there could be a disease-causing microbe that's being held at bay by commensals and stuff, but that's a general principle. The pathogen must then be isolated from the disease host and grown in pure culture. So to follow Koch's postulate strictly, we have to be able to culture the microorganism. So now we have a pure culture. We must be able to take that bacteria and introduce it into a healthy host, susceptible animal. We need an animal for which we have a disease model. It has to be an animal that can actually be infected by this microorganism. And we introduce it, and sure enough, the disease must be recapitulated, such as anthrax, right? If it's anthrax we're studying, we have a pure culture now. We should be able to introduce it into an animal, and it should look the same as the diseased animal. And then finally, that newly infected animal, we must be able to re-isolate and culture the organism once again from that animal, and it should look the same. We should get the same organism out that we had the first time when we cultured from the disease animal, the primary subject. So those are Koch's postulates. This is just a cartoon version of this thing, of everything that we just said, so I don't think we need to go through that all over again. Maybe I should have used that to describe it a little more entertaining. Well, part of the reason for bringing that up in this chapter is that Koch's postulates can't be used in every instance of discovering the etiology of a disease. And here are some possible exceptions, situations where we can't really follow Koch's postulates strictly. Okay, let's look at this one. Some pathogens cause several disease conditions. So just because we reintroduce it into a new host doesn't mean it's going to recapitulate the disease we saw the first time, because it causes multiple diseases. So that's a complication. Some pathogens cause disease only in humans. There is no animal model of the disease. So there's no animal in which to recapitulate the disease in order to re-isolate the bacteria. Third one, some pathogens can't be cultured. To this day, we can't grow particular bacteria. Treponema pallidum, the spirochete that causes syphilis, we can't grow it in culture, so we can't follow Koch's postulates. But we have established empirically very, very certainly that Treponema pallidum causes syphilis. Mycobacterium leprae causes leprosy. Not so easy to culture that one. Rickettsias, no culture model, no way to grow it in the laboratory without a host cell. It's an obligate intracellular parasite. Some viruses we've not been able to get them to grow, say, in embryonated eggs or anything else. So we just can't follow this rule. All right. HIV, an example of a viruses are very host specific. There's no other animal we can introduce HIV to recapitulate the disease, and we're certainly not going to take a healthy human and give them HIV infection in order to check and see if we're right. Well, the etiology, you get the idea. All right, so that's worth knowing about. Talking clinically, a symptom is a change in body function as a result of an infection that the patient can identify. When you take a patient history, the first thing you do when a patient comes into the clinic is listen. Listen to everything they have to say and write down everything they say. Maybe even prod them to keep talking and make sure they cover everything. And those are all symptoms. What did they feel? What did they notice different about their body? Then you can make some observations of your own. Signs are measurements that can be made in the clinic that can add to the symptoms. Now we have a list of signs and symptoms of a particular ailment, and together those things are called a syndrome. And we may immediately be able to make a relatively accurate diagnosis based on the signs and symptoms that are presented at the time of clinical exposure. It's called presentation, the presentation in the clinic. Okay, more definitions. A communicable disease is one that can be spread from one host to another. That's not always the case. Contagious disease is one that's easily spread. In fact, whether we like it or not, oftentimes. But a non-communicable disease cannot be spread from one host to another. It can be received, the inoculation can occur somehow that the person gets sick, but they cannot then transmit it to someone else in the community. Talking epidemiologically. Epidemiology is the study of the presence of disease in a population or a region or in all regions. The incidence of disease is the fraction of population that comes down with new cases in a period of time. How many new cases, say for example, came in a month or a year or a week, depends on, it could be any period of time. You may want to, because you may be graphing changes over weeks of time, for example, if it's a very contagious, fast-growing epidemic. Prevalence is the total number of cases over a period of time. Existing cases plus new cases. A sporadic disease is one that occurs occasionally in a population. Maybe a very, very low incidence of a particular disease or prevalence in a population. All of a sudden we just have some cases pop up and then go back down again. That's sporadic disease. Endemic disease, contrarily, are diseases that are always present in a population. So if we say malaria is endemic to sub-Saharan Africa, that means it's always there. There's always cases of malaria in the population in that part of the world. In most tropical regions of the world, there's a lot of mosquitoes and there's malaria being transmitted. An epidemic disease is one that's being, the incidence of disease is increasing rapidly in a short period of time. Right? We have a lot of new cases in a short period of time. That's called an epidemic. If that occurs in many different countries, maybe even different continents, that's called a pandemic. Same as an epidemic, we have a large number of new cases in a short period of time, but it's over a very broad geographic distribution, a pandemic. Herd immunity means that enough members of the population are immune to a particular pathogen that it can't spread. So if 80% of the population is successfully vaccinated against an organism, the vaccine is very effective so that people that are vaccinated do not get sick, then an epidemic will not arise because there's not enough hosts to create a large growing chain of transmission from person to person to create that kind of an epidemic outbreak. Well, here's a nice graph showing number of cases of a disease, HIV, AIDS in this case, in the United States over years of time. HIV, AIDS was first discovered in the 1980s, early 1980s, and the number of cases actually at the time, probably even in the 83, 84, 85 range, it wasn't very well understood. So what we've done is gone back and figured out how many cases were actually HIV, AIDS cases, and the numbers started to grow pretty fast. And then all of a sudden there was a huge increase in the numbers, and that largely reflects an expansion of surveillance. We really started to get down to brass tacks with looking in the population and and finding out who has HIV/AIDS and who doesn't. And so then over the subsequent period of time, the incidence has declined in the population somewhat as we've made efforts to educate the population and reduce behaviors that lead to communication of this disease. But still, way too many people with HIV/AIDS in this country. We need to do something about that. Sure, it'd be nice if we could get a vaccine or some way to reliably prevent transmission. Talk more about that disease. An acute disease is one that develops quickly, right? You were felt fine, the next day you didn't feel so great, and all of a sudden you have a disease, and it may subside just as quickly, or it may be a longer lasting disease. Chronic diseases last for a long time. They develop slowly and persist. We talked about persistent disease already. That could follow an acute exposure, acute disease that arises, and maybe it will become a chronic disease, or a chronic disease may typically slowly progress and persist rather than being intense all of a sudden. Subacute diseases, somewhere in between. Latent diseases are ones in which there's a period of time when there's no activity of the disease, followed by a reactivation. So we already talked about retroviruses and human herpes viruses that cause disease, and then all of a sudden there's no sign of any virions in any body fluid, and no signs or symptoms for a period of time, even years, and then all of a sudden reactivation and the appearance of symptoms once again. That's latency. You could have a local infection, an infection in some part of the body. If you get a cut in the skin, you might have an infection in your finger or something. You could have a systemic infection. You could have bacteria that have spread from a local infection throughout the body, a systemic infection. A focal infection started out as a local infection, became worse and worse until bacteria then spread from there throughout the body. Sepsis is a condition in which an infection is so bad that it's impacting the overall function of the body. So you have a bad infection somewhere in the body to the degree that it's affecting the whole body, the health of the whole body. It's affecting some vital signs in your body, for example, not just causing a local problem. This is a severe condition, by the way, sepsis. This is not just like, oh, maybe your body temperature went up like a fever. No, this is severe disease. Bacteremia means there's bacteria in your blood. Now, these are terms that get used kind of carelessly a lot of times, but strictly speaking, bacteremia means there's bacteria in your blood, and that can be transient or it can be something growing. If it's actually growing, our authors are using the term septicemia to mean growth of bacteria in the blood. Now, this emia suffix, which we may have encountered before, it means in the blood. So bacteremia means bacteria in the blood. Septicemia means a severe infection in the blood. It's growing there. Bugs are just in there growing at will in your blood. Very bad situation. You can have bacteremia momentarily after a bowel movement or after a dental procedure. Hopefully those bacteria will be immediately swept away by macrophages and so forth, and you won't persist. You won't progress to septicemia. Very unlikely. Toxemia. We've got the emia suffix again, only this time it's a bacterial toxin. Bacteria are forming an infection in your body and secreting toxins that are causing some disease state, maybe compromising some function of the body or killing some cells in the body, creating some problems. Sorry for all those pop-ups. Viremia, viruses in the blood. So some viruses have as part of their disease-causing cycle systemic transmission of the viruses or traveling of the viruses in the blood and the lymph fluid. A primary infection, acute infection that causes the initial illness. Secondary infection, once you get sick, sometimes another organism can get in and cause disease that wasn't causing disease before. So you may let's say you got a bad cold. You had an adenovirus or a coronavirus that caused a respiratory infection, but then a bacteria, while your immune system was kind of weakened by fighting this disease, some bacteria started to grow in your lungs. Now you have a secondary infection, you have a pneumonia. So that's a whole different thing, and you may need to treat that infection. Subclinical disease means there's an infection, but you don't even have any signs or symptoms. And that's exactly what happens if you have a successful immunization and you become exposed to the pathogen against which you were immunized. You'll never even know you have it. It's not that those things can't infect your body, it's that the immune response is so swift and vigorous that you'll never have any signs or symptoms. And then that will eradicate that from your body by the immune system. Predisposing factors for disease. Things that make it more likely for you as an individual or a group of individuals to get a particular type of disease. The short urethra in females, as we talked about briefly before, makes it much more likely for females to get urinary tract infections. It's just a shorter distance for microbes to have to travel up the urethra to get into the bladder and then beyond to cause a more complex disease, whereas the male urethra is much longer and it's quite rare for males to get urinary tract infections unless they have a catheter, a plastic tube placed in the penis, which is not uncommon if you have to go in for a major surgery, for example, and then that catheter can introduce microbes right into your bladder. Inherited traits. Sickle cell gene, for example, causes a particular disease. Climate and weather. Particular climates lend themselves to environments in which there are large numbers of particular microorganisms that cause disease, or possibly the transmission of diseases. Weather patterns. Dry, windy weather can blow a lot of microorganisms through the air from say, a farm where there's a lot of animals over to a population of people and introduce them to the disease. Fatigue. When you get tired, your immune system actually gets suppressed. And you've noticed this before, I'm sure, right around exam time every year, a lot of students come down with colds and teachers, right? Because there are a whole bunch of fatigued people that are worn out from staying up late, studying a lot and so forth, which is good for learning, but yet not so good for colds. So fatigue can produce susceptibility to disease. People, when they age, their immune system tends to wane a little bit and they become more susceptible. Lifestyles. People that have certain lifestyles are exposed to diseases and communicable diseases. Unprotected sex, for example, can lead to some very, very common diseases being transmitted in the population. Chemotherapy. People that get treated with chemotherapies, this term is often abused in our culture. When we say chemotherapy, we usually mean drugs that are used to try to kill cancer cells in the body, but they simultaneously suppress the immune system and make people very susceptible to all kinds of diseases after that, even other cancers, amazingly. Well, let's just take a look. Oh, there I go again. Let's just take a look at the stages, some stages of disease. And the y-axis is the number of microbes present in the blood, for example, over a period of time. And in these boxes are descriptions of the signs and symptoms that are being experienced by the patient, by the host. So initially we get exposed, say at the very zero time on the x-axis, and then there's a period of time in which there are no signs or symptoms at all. Microbes are just dividing. Maybe a virus has come into the body and it's just slowly beginning to infect more and more epithelial cells in our respiratory system. And then eventually we start to not feel so great. That's called the prodromal period. We know something's wrong. It's that feeling you get like, wow, I think I'm coming down with something. You're familiar with it enough. And it's not like you feel horrible, but you know it's coming. It's the prodromal period. There's some cytokines being released by, most likely by some white blood cells that's making you starting to feel funny. The period of illness, you have the sore throat, you have the runny nose, you have the cough, all the actual, the period of illness is all those signs and symptoms that are most severe related to a particular disease. I'm using a cold as an example. Then eventually your immune system gets some antibodies coming out and starting to knock back that virus, and we go into the period of decline. The signs and symptoms begin to wane. We feel better and better and better. And finally, we get to the period of convalescence where we don't really feel bad at all anymore. We may feel weak or washed out, but now we're really starting to get better. So those are the parts, the part you should be able to describe those different stages of infectious disease. There may be something that has to be done in order to reach this hump here. We may have to prescribe some antibiotics if it's a bacterial infection, for example, or we may never reach this decline period, depending on the disease. Reservoirs of infection. Where does our origin. What's the origin of our pathogen? Well, reservoirs. If there's a large number of microorganisms that we come in contact with, then that can certainly influence the transmission of disease. So humans, there might be a human who has a disease or is just getting over a disease. They are carriers. If they already have HIV virus in their body, they could transmit disease to another person. They have a lot of it in their body. They can transmit it. That's called a reservoir. Gonorrhea, another sexually transmitted infection. Typhoid, a salmonella disease. If someone has a lot of typhoid bacteria in their digestive tract and in their feces and they don't wash their hands well enough, they could easily transmit salmonella enterica, this salmonella typhi bacteria, to someone else. Animal reservoirs. Here's an important definition. Zoonoses are diseases that are transmitted from animals to humans. Now, most animal diseases, infectious diseases, cannot cause disease in humans. Most organisms that cause, I should say, infectious disease in animals do not infect humans, but occasionally they do. And so in this case, usually zoonoses are not transmitted from human to human. They're just acquired from animals to human. And so an animal could be a reservoir. An animal with rabies could bite a human and inoculate them with the lyssavirus and that we talked about last chapter. And they may develop the disease rabies. Lyme disease, deer ticks. Mice carry the Borrelia, and the deer then get infected, and they carry Borrelia, and then their ticks carry this Borrelia burgdorferi bacteria, and then when you get bitten by a tick, it can cause Lyme disease. So the animal reservoirs, where that's coming from. Non-living reservoirs. What if there's a can of food that has some botulinum toxin in there because some Clostridium botulinum endospores were present in the food that was prepared to can, and it was placed in the canning container, and that under those anaerobic conditions, the bacteria slowly began to grow, and some botulinum toxin was produced there. That's a reservoir of toxin that can come into our body. Same thing with tetanus. Clostridium tetani can produce a toxin by growing in an anaerobic location and an injury in the body where there's not oxygen, not good circulation, and you can have intoxication with this thing. Soil can have a lot of microorganisms in there, especially if someone is immunocompromised. That can be a reservoir of infection for all kinds of fungi and bacteria and so forth. All right, enough about that. What about the mode of transmission? Direct transmission means direct contact. Here's a direct transmission happening, and we have, who knows who's giving the disease to whom, but that means direct contact between individuals, one that's a reservoir and one's a susceptible host. Indirect contact, though, causes a lot of illnesses. Fomites are objects handled by someone that is a reservoir of a particular microbe, and then that is transferred onto the fomite and then handled by another person. So sharing a hairbrush or a cell phone or something like that, or a glass of drink. Someone might share a glass of drink, and that solution may have bacteria or viruses in it after that, or the glass itself, or any number of personal possessions. Exam papers, great one. Droplet transmission. If someone sneezes or coughs, or even just talking produces a lot of aerosols, microscopic droplets coming out of your mouth. You probably didn't know that, but I found out the hard way during COVID, wearing a clear visor over my face when I talk. Quite a lot of aerosols come out of your mouth when you're talking. I used to spatter all over the visor, and it was quite an uncomfortable discovery. So that's droplet transmission. So if someone is a reservoir, they can transmit droplets to another person through the air, and they can become inoculated and become sick. Vehicle transmissions. Food, water, and air are different vehicles that could carry microorganisms from reservoirs to another host. So here you see somebody doing something unrecommended. No matter how hot it is, no matter how clean you think that mountain stream, this doesn't even look good, right? Who in the world would bend down and drink that murky water? But sometimes you're out hiking on a hot summer day in a beautiful mountain pastoral setting, and you see this crystal clear stream bubbling down through the side of the mountain, and you think, you know what? That is the most natural and pure natural thing in the world. You want to bend down and drink it. Well, don't do it. It's very possibly a vehicle of transmission to some very memorable GI diseases you'll acquire. Food. If this food prep worker has salmonella enteric, as we mentioned before, and she doesn't know that it's on her hands, she may transmit it and place it in the food, inoculate the food, and then that becomes a vehicle by which all the people that eat that food will become infected. Air. Look at this dusty, dry air. If there's some microbes in this dusty air and the wind comes or they sweep it up, it may travel in the air and infect some people. That's an air vehicle of transmission. Vectors. Arthropods, bugs, can carry disease from one individual to another. And so arthropods include some pretty important ones: fleas, ticks, and mosquitoes. Flies, we should throw in there, can transmit disease. They can either transmit by mechanical transmission. If a fly lands on some reservoir of disease and then lands on your food with its little nasty feet, it may release some bacteria into the food and transmit disease. That's called mechanical transmission. Biological transmission involves reproduction of the microorganism in the microbe, or in the arthropod, I mean. So pathogen reproduces in the tick, or in the fleas, or whatever it might be, or in the mosquitoes, and then they transmit the disease to the new host. And there's a mechanical transmission happening in this otherwise delicious looking preparation of, if you like that sort of thing, a hamburger. It looks like with some cheese on it, some ketchup, and here we go. But oh no, look what just landed on there. If you're like me, you say, brush it away and eat it anyway. But you could get disease from it technically. Pretty unlikely, but possible. We live in a pretty sanitary kind of environment. Here's a mosquito taking a blood meal. At the same time, saliva from the mosquitoes going down into the skin. And if the mosquito is a carrier of particular microorganisms like yellow fever or malaria or something like that, then there's going to be a transmission of disease through that vector. We also mentioned Borrelia burgdorferi. Ticks transmit Lyme disease. Ticks transmit Rocky Mountain spotted fever, and so forth. There's a lot of vector transmitted diseases out there. Nosocomial infections. Another terminology for this chapter: nosocomial infections are ones that are acquired in the healthcare setting. If you go to the hospital for a period of time, if you get sick enough that you have to spend some time in the hospital, there's an excellent chance that you'll get sick of something that you acquire in the hospital. 5 to 15% of all hospital patients, and I think if we adjusted these statistics for days of stay in the hospital, we find it's much, much higher than that if you spend more than a casual period of time in the hospital. And so there's a lot of reservoirs there and modes of transmission. Nothing you can do about it. There's a lot of sick people in the hospital, a lot of people having to handle them, like it or not, and then having to handle new hosts coming in, new patients. We make every effort to avoid transmission of disease using personal protective equipment, PPEs, using sterile gloves that are constantly changed, using masks, and preventing our hair from falling down into this wound, washing hands with disinfectants and antiseptics. Try to get ourselves as clean as we possibly can, using all sterile new drapes and gauze and everything else. But nevertheless, sometimes infections occur. Boy, has we come a long way since the olden days. So you have microorganisms in the hospital environment that are present. You have a compromised host. Someone came in there probably sick or had a surgery or trauma, and now there's that susceptibility. Then you have a way of transmitting. So someone who handles one patient that has a microorganism already is now going to handle that other patient. You have a mechanism for transmission, a chain of transmission. Now you have nosocomial infection. Just by different types of infections that people get. Here's a little breakdown of the types of infections. Urinary tract infections, 32% of nosocomial infections are urinary tract infections, largely because of catheters that are placed in the urethra. For people if you go under general anesthesia, you're very likely to get catheterized, but not necessarily. Depends on the situation. Surgical site infections, right? If you have a big surgery, there's a chance you'll get an infection in the wound, and you have to have some treatment for that. Lower respiratory infections, pneumonias, and so forth, bloodstream infections, and others. So there's a lot of different routes by which microbes can get into your body and cause disease, and there's a representation. What are some common microorganisms that cause nosocomial infections? Staphylococci, coagulase negative staphylococci produce something like 15% of infections, and something like 90% of them are antibiotic resistant. So not only do we have this source of microbes in the hospital, they're often antibiotic resistant microbes because we've been battling them from patient to patient forever, and the bacteria have developed resistance, and that's a big problem. Big problem, growing problem. Staphylococcus aureus causes about another 15% of nosocomial infections, and about 80% of those are now antibiotic resistance. We'll talk about MRSA in just a moment. Enterococcus, very common intestinal bacteria, 10% of nosocomial infections, a lot of antibiotic resistance. You'll hear about vancomycin resistant Enterococcus. That's VRE, it's called, as opposed to MRSA for Staph aureus that are resistant to methicillin. Gram-negative rods, right, all the enteric bacteria in the intestine, a lot of resistance starting to occur. So this is becoming a great big problem, as Clostridium difficile causes a fair amount of trouble in the hospital as well. We don't have a number for antibiotic resistance on those guys. Methicillin resistant Staphylococcus aureus. They're everywhere. They're everywhere. Something like 92% of Staph aureus strains in the hospital are now MRSA. And about 89% of community-acquired Staphylococcus aureus infections are now methicillin resistant. So it started out as just a nosocomia problem. Now there's resistant staph everywhere, all throughout the community. If you get into a pickup league game and get banged into somebody who has MRSA, has a staph infection, it's a very good chance it's a MRSA infection. So now you're going to be at a little more of a risk. You have to find another antibiotic besides methicillin, a completely different type of antibiotic to help cure that. Eventually, we're going to run up against more and more microorganisms that are resistant to all antibiotics, and we're going to have a lot of trouble on our hands. Okay. What was that title? I don't know. What are the most likely routes or reasons or modes of transmission of nosocomial infections? Hemodialysis. People have indwelling catheters in their body, tubes going into a vein in their body in which we can take out blood from the body, pipe it into a machine that takes the place of your kidneys and does dialysis, and then pipe that blood right back into the body. And biofilms can form on those catheters, and people can get infections, and they're oftentimes methicillin resistant, or oftentimes it might be Enterococcus. Equally big, or if not a worse problem. Intravenous catheters. So other types of intravenous catheters. People come into the hospital with severe illness. They're in the intensive care unit or in a fairly high level unit. They probably have an indwelling catheter in their vein with a little port on there for the people to introduce drips, various types of IV fluids and so forth. And those catheters can introduce infections. Surgeries, big time introduction of infections. Bladder catheters, Foley catheters, and so forth cause a lot of infections with MRSA and with other types of bacteria. Ventilators. In other words, you have to put someone on a ventilator, you have to intubate them, it's called. You take a plastic pipe and shove it down into their trachea through their oral cavity, and there's lots of microbes in the oral cavity. You're going to carry them right down into the respiratory system, which is otherwise, under normal conditions, a sterile environment down there, down beyond the larynx. So which antibiotics are bugs becoming resistant to? Vancomycin, fluoroquinolone, ciprofloxacin is a fluoroquinolone. So a lot of people get treated with these antibiotics, and what often happens is we select for antibiotic bacteria, and eventually we wind up with a bunch of antibiotic-resistant organisms on our hands. Emerging infectious diseases. Um, there are some infectious diseases that are relatively infrequent in our population, but they're starting to grow in numbers. Those are called emerging diseases. There's a lot of different ones out there that we could list. Here's contributing factors listed here. What are some examples? E. coli O157H7 is a strain of E. coli that contains the genes to produce Shiga toxin, which causes intestinal dysentery, a bloody diarrhea, damage to the epithelial lining, very, very severe diarrhea. Quite a terrible thing indeed. So people actually die of E. coli exposure. When you hear about this summer, keep your ears open in the news now that you're a microbiology expert, and you'll hear people talking about, oh, so-and-so went to the fair and ate some bad hamburger and got E. coli. That's all they say. And people think, oh, E. coli. No, E. coli is present in unimaginable numbers in your intestines, and they're important because they help crowd out pathogenic bacteria. It's only occasionally that a strain of E. coli gets a hold of a virulence factor, a disease-causing gene, and now it becomes a bad E. coli. So always when there's a disease-causing E. coli, there will be a strain number like this associated with it, so we know what we're dealing with there. Influenza. There are influenzas that come out around the world, and they tend to go into common hosts. Multiple strains of influenza go into common hosts. They shuffle basically their genomes, and out comes some brand new strains of virus that have never been encountered before, and sometimes they cause very severe disease, and they emerge in the population. Every 10 years or so, an extra nasty strain of flu comes along and causes a pretty bad epidemic and pandemic. Evolution of new strains. Vibrio cholera that acquires some new virulence factors, maybe from horizontal gene transmission and so forth. Now we've got an emerging disease on our hands. Inappropriate use of antibiotics and pesticides. It's believed that antibiotic-resistant strains of bacteria come from excessive use of antibiotics, but I will point out that even if you don't do what you think is excessive use, eventually using antibiotics will result in resistance. So they always put abuse, but I'll tell you that's a little bit like absolving yourself of guilt for something, because just using antibiotics, which we do because it's a wonderful world we've created in which we can treat infectious diseases with antibiotics, well, the result of that is over generations of time, resistant microorganisms, and that's just the way of it. Hantavirus is a type of virus that's transmitted in rodent urine. So in parts of the world where there's a lot of, in locations where there's a lot of rodents in the population that are not well managed and they're just traveling around and cohabitating with people, they can transmit disease, and certain climates lend themselves to transmission of hantavirus. Kind of a nasty thing. Modern transportation, West Nile virus. West Nile virus was something that came from Egypt relatively recently. It had never been in the United States or in North America whatsoever, and then because of people traveling back and forth all over the world, there's no region that doesn't interconnect with another region, of pretty much all other regions, at least to some degree, by modern transportation. And now the virus has been found in North America and has been increasing in incidence in the northeast of the United States for quite a few years now, and is getting kind of to a scary degree. It's carried by birds, and then mosquitoes bite the birds and then transmit it to humans, and you get an encephalitis infection right in your brain. It's kind of scary. There's a whole bunch of emerging encephalitis viruses from different regions of the country. Ecologic disaster. You can imagine what happens when you move great populations of people around in war or in can't think of the word I want. Displaced populations during war. What do you call them? Refugees. Large numbers of people moving around and transmitting disease. You have emerging diseases that are in those populations, spreading throughout the population and forming a giant reservoir, and then it's an emerging disease occurring in a geographic region. Spanning human settlement into areas where microorganisms are plentiful, but normally there hasn't been much exposure. boom, now we have a lot of people in this area where a lot of these bugs are. Coccidioidomycosis is a fungal disease that's increasing in incidence in certain areas. Animal control measures, Lyme disease. I'm not sure what they're getting at there entirely. To think about that. I'll have to read in the text. I should have written the text, but I'm not sure how they're thinking that animal control measures are leading to an increase in Lyme disease. I guess one thing it could be is areas where it's not legal to hunt deer. So deer are just taking over, just overrunning suburban areas all throughout the northeast of America. Huge numbers of deer ticks now, and hence the spread of Lyme disease is probably what they're talking about. Public health failure. Diphtheria is a terrible, terrible respiratory disease that was nearly eradicated by vaccination. The DTP vaccine, DTAP vaccine, one of the things it inoculates all children against is diphtheria. But people are getting into this faddish notion that they know better and that vaccines are dangerous and therefore we shouldn't vaccinate our children. And what's happening is we're losing herd immunity among the population, whereas diphtheria was essentially gone from the population in North America, is starting to arise again because people are not getting vaccinated, and it's entirely misdirected people who are falling victim to misinformation, who are not vaccinating their children, and their children are at risk, and therefore they're putting other people at risk for diphtheria. So it's a crazy, crazy world that we live in today, in which medical information is viewed as being either false or suspect, and we don't need to follow any medical advice. We as individuals, or as our popular website of interest, knows better, which is truly ludicrous. Here's just a little diagram showing how different strains of influenza that have different host ranges can co-infect particular hosts, and then by reassortment is called, the different genes within. You can see that there's influenza virus has numerous pieces of RNA that make up its genome, and it can interchange pieces among other strains of the virus, so that a brand new strain, which represents a unique combination of genes that's never been together before, can emerge from such a host that had multiple infections at the same time. That's the theory on how different avian influenza species and swine influenza species and human influenza species can reassort genes and cause new strains that have different host ranges and different virulence. I'm going to call it right there. I've been talking for a long time. I was hoping I could finish up this chapter, but I think I'm going to make it a little bit too long of a recording, so I'm going to stop there and finish up whatever is left in part 2 of chapter 14.